Hello? 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 Time for learning. All right. 58 played. Madison Miller and Courtney Westcott. Are you here? You're going to make me walk all the way up there? Which one are you? Where's Madison? Madison Miller. Oh, goodness. -5 for Madison Miller. All right, I'll email Madison. All right. Everyone survived GI in 51 minutes yesterday? Sorry to do that to you, but it's really better not done in 51 minutes. All right, here's the other topic I get to talk about, clotting. So either preventing excess clotting or encouraging clotting when it needs to be encouraged. Again, I have some objectives. I'm going to break this down into phases of hemostasis. And so kind of want you to take that perspective. What phase of hemostasis, and does this increase or decrease clotting, and how does it do that? And other useful bits of information. I think last year I finally got the test questions where I wanted them, where I wasn't too picky, but I expected you to know some things. This is a review. I think these are the same images that Dr. Lee used. Did he talk to you about hemostasis last year? Okay, well, here we are again. Okay, remember there's a vascular phase, vasoconstriction. So you damage a blood vessel constricts. All right, so we're decreasing blood flow to the area. Off the top of my head, I don't think we have any drugs actually that act there. Second phase, platelet phase. This is where the platelets come in and then they start aggregating. Okay, that's called primary hemostasis, and we have some drugs that target that phase. Next phase, secondary hemostasis. That's called the coagulation phase. Now we're getting the clotting cascade involved. All right, and so more clotting happens. You know, platelets are getting stuck together. Fibrin forms, kind of grabs everything and tightens it up into a clot. We do have some drugs that target there. Then there's the antithrombotic and fibrinolytic phase. Antithrombotic is now we're slowing down the coagulation cascade so your whole vessel doesn't fill up with a blood clot. I think we do have some drugs there. And then fibrinolytic phase, that's where we're breaking down the fibrin clot, and I don't think we have any drugs there. So that's kind of how we're going to do this. You will encounter problems with clotting, either not enough clotting, okay, and I've just listed a bunch of them that you'll run into as you continue to study veterinary medicine, or too much clotting. The big problem is formation of blood clots, thrombosis, which can be associated with a whole bunch of different diseases, cardiac, renal diseases, things like that. So you will occasionally run into these issues if you have patients. If you're an internist, you'll probably be running into them a whole lot more. Here's the drugs we're going to talk about today. The ones in parentheses I'm just going to touch on, so I'm not going to hold you to memorize them. But the other ones I do want you to understand. And I got those by phase. Actually, there are fibrinolytic phase ones. It's just we're not going to put a whole lot of time talking about them. Okay? So let's talk about the platelet phase. Okay, this is where what basically happens, if you recall, is you get a damaged blood vessel. Okay, and there's von Willebrand factor, and that's something that tends to, it's in several places. It's floating around in your blood. It's also in platelets and released when the platelets start to aggregate together to kind of keep things going. So von Willebrand factor basically serves, let's see, where is it? It says purple chain. Okay, kind of looks like a chain of grapes. So it's a purple chain, and the platelets are going to adhere to that using this GP receptor. All right, and then there's other receptors, GP receptors, that are going to hang on to fibrin and kind of pull things together. So this is just the platelet phase. Von Willebrand factor tends to be an important part of it. Okay, it's circulating, I mentioned. It's in platelets some. It's also in the endothelial cells, so it spills out when they get damaged. First thing I wanted to touch on is there's a disorder called von Willebrand disease. All right, Dobermans, if I recall, tend to get that. There's two forms. There's hereditary and acquired. First form, and I'm not here to lecture you on von Willebrand disease, but the first form is, so I'll make it short, type 1 is you have decreased levels of von Willebrand factor. So von Willebrand factor isn't there as much when you're trying to form a clot, so that's going to interfere with this platelet phase. Type 2 is you don't have von Willebrand factor at all, or actually I'm lying, it doesn't function properly. It's there, but it doesn't work. Type 3 is you're missing it, no von Willebrand factor. So there's three different von Willebrand diseases. Let's say you needed to do a surgery on a patient with von Willebrand factor. You know this patient's going to be prone to clotting, or not clotting, bleeding, hemorrhaging. Okay, what can you do about it? Well, there is a drug called desmopressin acetate, or DDAVP. Actually, if you remember vasopressin, antidiuretic hormone, it's an analog of it. It differs, here's, let's see, here's vasopressin, here's desmopressin. Okay, and just a different, differs, here's an amine, here's an H, and then the arginine is a different isomer. So it's pretty darn close to vasopressin, but it differs enough. And what it does actually is it binds a different vasopressin receptor. And so you don't get quite the antidiuretic effects, you get a little bit. But instead, what it does when it binds that receptor is it causes release of stored von Willebrand factor. Okay, so let's say you had a surgical patient. You know they got von Willebrand's disease and you know which type. Which type would desmopressin be good for? Releasing von Willebrand factor before you go to surgery, so when you do that cutting, your patient is going to clot their blood better. Which of the three forms is it useful for? Yeah, type 1, because at least you have some von Willebrand factor there, and it functions properly, but you just don't have enough. So it is useful in that circumstance. I mentioned that. I ran into this drug when I was an intern, and the surgeon and someone else was talking about it, and I was standing there and like, well, damn, I never heard of this drug in vet school. So I'm mentioning it to you today so you're familiar that there is an option actually with von Willebrand's disease, and also so you don't feel stupid when you're out there and people smarter than you are talking about desmopressin, and you're like, oh, I know what that is. That guy taught it to me. All right, so platelet phase. Here's what happens when platelets get activated. I may not have done the best explanation here, but let's talk about the activation part, okay? When platelets get activated, so they bind these receptors initially, and they get bound to von Willebrand factor, you release a bunch of mediators. If you remember thromboxane A2 being in platelets, here's thromboxane A2's big moment, okay? It gets released. Also ADP, not ATP, but ADP, okay, gets released, and other signals also get released. The ADP, we're going to focus on that. That binds these purine receptors, which are sitting on platelets. So here's a platelet being activated. Okay, it's bound von Willebrand factor. It's spewing out these guys. All right, and it's going over to this next platelet in the vicinity and turning that on. Okay, so what happens when this purine receptor gets bound? Let's see, is that on this picture? No, we'll look on the next page for a better diagram. When this purine receptor gets bound, what happens is another receptor in the platelet gets put on the cell surface, and this is called glycoprotein 2B3A receptor. And so I'm going to show you what that does. When that gets put on the surface, that's actually what, here's that guy, okay? That's actually what allows, it's actually fibrinogen that gets bound. And so the platelets start sticking together, and then eventually a clotting cascade is going to change that fibrinogen to fibrin and kind of bind everybody together. All right, so why do I mention all these steps? Because they're kind of, as we look at the drugs, you'll see how the different ones are important. So I'm going to touch on aspirin, which is a salicylate. The aspirin itself is called acetyl salicylic acid. Used to be used a lot. You know, it'd be the go-to if you had a headache or things like that, at least on the human side. Now it's mainly used in microdose. So I think the tablets used to be 325 milligrams. Now there's an 81 milligram that people who are prone to blood clots take. So it's kind of a low dose, but it does the trick. What it does, you haven't had your NSAID lecture yet. If you remember prostaglandins and thromboxanes and things like that, they get created from arachidonic acid. So if you think way back to a year ago, the cyclooxygenase enzymes do that. They're also called COX, COX-1 and COX-2, okay? And they form prostaglandins and thromboxane from arachidonic acid. So you can kind of see this here. They get this cascade going. And then there's different enzymes where you can make different prostaglandins and make thromboxane. In the platelets, cyclooxygenase 1 makes this prostaglandin, and then this enzyme goes on and makes thromboxane A2. Thromboxane A2 is very important for this aggregation of platelets. Okay, that's one of those mediators that gets released. Aspirin blocks this guy. Okay, it's an irreversible inhibitor. So it blocks right here. So you don't make as much thromboxane A2. That's why I X this part out, okay? Because of that, that function of platelets releasing thromboxane A2 is inhibited for however long the platelet is around, which is about 7 to 10 days is how long platelets live, okay? So you're not going to be able to do that coagulation. So that's why this is used in people who are prone to throwing blood clots, is it kind of a low grade keeps you from being extra coagulable, all right? This is also why if you ever go in for an invasive procedure at your physician's, you're going to get a question about have you taken aspirin or other drugs. Now because this is irreversible, what are the implications of that? Irreversible means it binds and doesn't unbind. It permanently changes.
If you take too much, you're not that way.
Well, true. Aspirin toxicosis is a bad thing. So, but just even at normal doses, it lasts longer. That's why you got to get new platelets to have that effect go away, because it's going to affect those platelets for the lifespan. That's the implication of it being irreversible versus a reversible one would be more temporary, wouldn't last the life of the platelets. Other NSAIDs also inhibit cyclooxygenase, but they're reversible, so they don't tend to have as much of an effect on coagulation. And then I'll save NSAIDs for whoever's going to be covering that in this course. So it is used to inhibit clot formation. You can't dissolve a clot with it. You can try to inhibit it or prevent a clot from getting worse. So it is used sometimes, mainly in small animals. Cats, more so dogs, occasionally horses. They get intestinal parasites and then they get blood clots in the intestinal vasculature. It's used occasionally. It's being replaced by, we're going to talk about clopidogrel, which is basically a safer drug. And now we're going to talk about why aspirin's a problem. This is a feline saddle thrombus in a cat, though, that obviously is dead. Have you guys heard about saddle thrombi? All right. So if you got a patient that you're worried about, you might start them on aspirin. This is why you're probably better off reaching for other drugs, but you may find yourself using aspirin occasionally. It's pretty cheap. All right. It loves ulcerating the gut, the stomach, and the intestine. All right. So these are like some little pinpoint hemorrhages. This is endoscopy on a stomach from aspirin. These are more linear erosions of the gastric mucosa. Cyclooxygenase 1 has these protective functions of the gut that it mediates. It cranks out mucus, more blood flow to the lining of the stomach, of the intestine, increases bicarb secretion, so it protects against stomach acid and the other enzymes. All right. Problem is, if you block that to get aspirin's effect, you're diminishing those protective effects. So that's why it really tends to like to cause stomach ulcers, is you're taking away that ability to protect the stomach. This is a study that shows it's got placebo, aspirin. Here's a couple of NSAIDs that are obviously not salicylate NSAIDs. And it just shows they developed a scoring system for GI lesions, ulcers. Okay, so day 0, day 5, the aspirin group's already all the way up here with having GI ulcers. The others not so much, and this was maintained through 28 days of the study. So it likes to cause ulcers, and it likes to cause them fast. All right, another reason, especially cats don't metabolize it well. Their half-life is way longer than in dogs, and that's because, did you guys talk about phase 2 metabolism? Cats don't glucuronidate so well, and that's one of the main steps to inactivate aspirin. All right, and another reason to be hesitant, some patients it works fine, and some patients it really doesn't work at all. And it's nice to have a drug maybe that works most of the time, and aspirin is not necessarily true as far as that aspect. So that's why we're seeing a migration to other substances. Here's where clopidogrel comes in. Its brand name is Plavix. It too is an irreversible, it's an antagonist, so it blocks these purine receptors that I mentioned. So here's the better slide of what happens. All right, remember, we get damage, we get ADP release, it's also coming from platelets. It binds this receptor, and normally that leads to calcium influx. And what happens then is these guys, these GP2B3A receptors, they get put on the cell surface, and then they're the ones that are going to bind on a fibrinogen. Well, what this does, clopidogrel, is it blocks this receptor here, so ultimately you don't wind up putting the receptors on the cell surface that are going to bind fibrinogen. All right, so you're kind of decreasing stickiness of platelets to fibrinogen. All right, so it is also used to inhibit thrombus formation, and actually, because it turns out to be fairly affordable and fairly safe, you'll find it used in a lot of other applications too. Maybe it's not a perfect fit, but you want to do something to try to inhibit excess clotting, you would reach for clopidogrel. Couple things about it. Do you know prodrug? Had you heard that term before? All right, so it's a prodrug, liver, P450s, turn it into an active metabolite, and then it goes and does its thing. You give it orally. You give it once a day. That's nice. It's been used in dogs, cats, and horses. All right, so we got some species we cover. You don't have to monitor blood clotting as closely as you do with some other things, so that's very nice. Yes, you do have a risk sometimes of hemorrhage or GI upset. It's a pretty low risk, though. It's far better than with, it's better risk than stomach ulcers with aspirin, or we're going to talk about warfarin. It's a better drug than warfarin as far as avoiding side effects, okay? So this is a drug that I think you'll be using more as you're out in practice. Dr. Brainard is very enthusiastic about it. I talked with him and Dr. Barden when I put this lecture together, got a feel for what drugs they're using. Okay, so it is something that I think you'll be using more than in the past. All right, how are we doing so far? Great. Okay. Well, I find these topics interesting, even if you guys don't. Coagulation phase of hemostasis. All right, you remember this? Intrinsic pathway, extrinsic pathway. This involves collagen exposure, like when the endothelial cells get damaged. Extrinsic is deeper damage beyond the endothelial cells. Factor 12 all the way down to factor 10 gets activated. Factor 7 to factor 10, you get this complex, which is activated factor 10, activated factor 5, and calcium. Takes prothrombin to thrombin. Thrombin takes fibrinogen to fibrin, those fibrin strands that are going to pull things together. And then here's where factor 13 gets to do its thing. All right, so in a nutshell, that is the coagulation cascade. So I liked this meme when I saw it because I've always wondered, why are we going with the Roman numerals? Though it does give a little bit of class to the coagulation cascade, so maybe that's it. And then you get the end result. And here's a couple micrographs of clots, like this is platelets, red cells, here's a white cell, lots of fibrin. I think this one actually is probably more accurate. So it really shows those red blood cells just kind of crammed in there with the fibrin around it, okay? Let's talk about warfarin. This will come up again in your toxicology course. Initially, it was discovered, or the path to it being discovered, was moldy sweet clover poisoning in cattle, which would cause hemorrhage. So they'd eat sweet clover that had mold on it. What that did is made dicumarol, which is a compound that serves as an anticoagulant and interferes with the coagulation cascade. From that, the drug warfarin was synthesized. And actually, warfarin and dicumarol, both of these are still used as anticoagulants or blood thinners. They're slowly being replaced by safer things, okay? But they're still used. And then warfarin also was turned into an anticoagulant rodenticide. Eventually, that's not used as much because the rodents had to eat multiple meals of it, and it wasn't quite that potent, so stronger ones were invented. But this is how, I'm going to tell you, this will be how anticoagulant rodenticides poison your patient and hemorrhage occurs. Notice that structurally, these are very similar to vitamin K, which is critical for coagulation. So maybe you can see where this story is going. There's 4 vitamin K dependent clotting factors, 2, 7, 9, and 10. Those are ones that I would kind of memorize. I call that board information, okay? What happens over here is you need vitamin K. There's this carboxylase that takes these from inactive form to active form, the coagulation factors. And this carboxylase, it depends on vitamin K to do its job. All right, so you take vitamin K, here's the form you would have floating around. It activates the carboxylase. You get your active clotting factors, and then you get this inactive form of vitamin K. You can regenerate that, though, through these 2 enzymes, this being the more sensitive enzyme, okay, or the one that there's actually, this has a couple of ways to do this job. This one, there's only one job. Vitamin K inhibits vitamin K epoxide reductase, so you cannot regenerate vitamin K, and therefore you can't go activating your coagulation factors. So what happens is you get stuck using the coagulation factors that are, these are not quite the, you know, like 10, 10A. These are not the A. These are the 10 form that are kind of ready to go to be activated. All right, you use those up, and then suddenly you're out of clotting factors because you can't replenish them. All right, so that's how warfarin works, because it inhibits this enzyme, and ultimately you run out of your ready-to-go coagulation factors. Does that kind of make sense? All right. In most species, not necessarily horses, but in most species, factor VII depletes first. These are a couple of tests, prothrombin time and partial thromboplastin time. You'll talk about them in ClinPath and/or toxicology, that you can use to assay the intrinsic side and the common side, or the extrinsic and the common side. So anyway, VII depletes first. So if you're testing for it, usually a prothrombin test gives you an idea if bleeding's becoming prolonged before the other ones. Then these other guys deplete, 2, 9, and 10. So you've taken out all 4 of these factors, okay, including thromboplastin, factor 2, right? So you're really hitting this coagulation cascade in multiple spots where it cannot proceed. So you lose the ability to form your fibrin clots. So warfarin is used as a therapeutic, and again, it's starting to kind of lose favor because it has issues. It's good for preventing thrombotic effects in dogs. Doesn't seem to be as effective in cats. On rare occasion, it is used in horses. It's highly protein bound, so if you hear that phrase, hopefully that means to you look out for drug interactions. The only good thing about it is it has a short half-life. So if you get into trouble with warfarin, you basically give some vitamin K and cross your fingers, and within a couple days they'll clear it out. Here's why we don't use it so much anymore, and the same reason in human healthcare. Okay, you really got to watch clotting closely. So you use these coagulation tests, because you're using it to try to prevent blood clots, and if you don't have enough of it, well, you're going to probably get those clots. That's bad news. If you get too much, they can easily start hemorrhaging, which is what happens with warfarin poisoning, okay? And usually you like to hemorrhage into your body cavities, so your abdomen or your chest, but you can hemorrhage elsewhere. All right, so it's kind of a real balance, and you got to be checking prothrombin time and maybe activated partial thromboplastin time frequently. It tends to vary between individuals on how well it works. Lots of drug interactions, not to be used if somebody's pregnant. So clopidogrel is kind of taking over as the go-to for this, but you will still encounter its use some. Here's the flip side. If you have too much warfarin or another longer-lasting, more potent anticoagulant rodenticide, you can give vitamin K. And the form you want is vitamin K1, okay? We do make some vitamin K in our gut, and then there's also a synthetic form of it. This is primarily used if you overdo it with the warfarin in your patient or anticoagulant rodenticide exposure. Here's a dog with abdominal on the surface of the abdomen hemorrhage. All right, and this has been used in my years in poison control. I talked with people about vitamin K in dogs, cats, horses, goats, chickens, rabbits, and I'm sure there's some other ones in there. So all these guys like to get into the rodenticide, all right? So this one you'll probably be using a lot, all right? And it's for the specific reason if you have a warfarin type issue. Good things, you can give it with food. It does take about 6 to 12 hours to take effect, so if your patient's bleeding, you better maybe, you'll give it, you'll cross your fingers, and hopefully give some clotting factors or something like that if plasma is available. All right, you want to try to keep it within the dose range because it actually can oxidize red cells. You can give the injectable product orally. This works great for little things that need it, all right, like puppies. And last thing I'm going to leave you with is don't give K3 to horses, because horses just don't do well with that. It damages the kidneys. So this is a drug you will be using a fair amount. Okay. How are we doing so far? Yeah? All right. Now, factor 10, remember, those two pathways come together there, so it kind of makes sense. Wouldn't it be cool to have a drug that kind of zeroes in on factor 10? And the answer is, yeah, we've got a drug like that, okay? So what it does, and so rivaroxaban, which is brand name Xarelto, and apixaban, which is Eliquis, all right, it basically comes in and inhibits factor 10A when it gets activated, and also this prothrombinase complex, which is factor 5A, 10A, and calcium. It inhibits this, so you have less prothrombin going to thrombin and ultimately less fibrin. So this too is used as a anticoagulant. And it has seen some use, and it has been evaluated some in veterinary medicine. Okay, you can give it 1 to 2 times a day, depending, so that's nice. You don't have to give it too frequently. Tends to act fairly quickly, so that's good. You don't have a great risk of hemorrhage. You still want to keep an eye on clotting profiles, but not anywhere as frequently as you would with warfarin. Okay, and at least dogs and cats seem to tolerate it pretty well. And so it has been looked at in studies with immune-mediated hemolytic anemia and other types of thrombotic problems in dogs, and we do know the pharmacokinetics for dogs and cats. And this is for the rivaroxaban. Apixaban is also starting to be looked at too. So this is another drug that I think you will be looking at as to prevent clotting in your patients who are prone to forming clots. Okay. All right, you guys can read that. That's the face that you're going to have as a practitioner when you hear really stupid stuff, which you'll probably be hearing at least once a day, if not more often. So you should get used to practicing that face in the mirror, where you can see, if you know what you're looking for, you can see the subtle disappointment and irritation, but it's not too evident. All right, now we're on the antithrombotic phase. Now we want to kind of slow down blood clotting. All right, the big thing that does that, there's 3 different things that kind of play a role. The ones we're going to focus on is you've got this antithrombin 3. And so what that does, that's floating around in your bloodstream, and it inhibits thrombin, the activated factor 2, and also factor 10A and some other factors. So we've got something here to kind of slow down coagulation once it starts occurring, because again, you don't want your whole blood vessel to fill up with a blood clot. You just want to seal the defect and then slow things down. So this is an endogenous mechanism to keep you from clotting too much. All right, antithrombin 3 then, you got heparin that's expressed on the endothelial cells. Antithrombin 3 then can also come along and bind to heparin, all right? And that actually makes it a lot more efficient in doing its job. So we're going to talk about this, and particularly we're going to talk about heparin. Heparin can be given as a drug. Heparin is a glycosaminoglycan chain. Do you guys familiar with glycosaminoglycans? You familiar with joint supplements for dogs with arthritis? Okay, those are glycosaminoglycans. They help nourish and encourage new cartilage to reform. What else? Glycosaminoglycans are kind of found in your extracellular matrix. This particular sequence of glycosaminoglycans is found in your endogenous heparin lining your blood vessels. All right, and what it does, again, It's what's called an allosteric modulator. Did you guys talk about that in pharmacology earlier on? Things that are allosteric modulators? No? All right. They basically kind of change the shape of an enzyme. In this case, they help it work more efficiently. That's all there is. So when oh my gosh, who binds this? Sorry, having a memory block. All right, when antithrombin 3 binds heparin, the heparin kind of changes its shape so it does a better job. In fact, it makes it up to 1,000-fold more active, so that's pretty good. So it really ramps up the inactivation of thrombin in 10A. This is reversible, so that's good, all right, because if you overdo it with this or you change your mind, the effect will wear off after a little while, okay? Keep in mind it is dosed in units, not milligrams, okay? So units, so you got to make sure you don't screw that up. I've seen that happen before, okay? This little sequence here on the heparin is what actually mediates that main effect. It's a sequence of 5 specific glycosaminoglycans together. 2 types of heparin. This is going to be a test question because compare and contrast. You can give unfractionated heparin or you can give low molecular weight heparin. This is a lot better in many cases, but it's a lot more expensive. All right, so you're going to hear that a lot in your career in veterinary medicine. Yes, ma'am?
I was just wondering, on the previous slide, when it says what happens if you give it IM?
Yeah. Oh, yeah. Did I have that? Oh, what do you think? Why would I not want to give a big lump of...
Well, I wanted to get into the bloodstream.
Yeah, besides issues of getting into the bloodstream. So other drugs you can give IM and they'll diffuse from the interstitial space into the vasculature. What does the drug do?
Could it lead to local hemorrhage in the muscle because when you inject it, it's preventing clotting from happening there?
Yeah, yeah. So you get a nice hematoma potentially if you jab that heparin IM. Okay, muscles like to bleed; they're very vascular. And you go stick a big bolus of anticoagulant in there. So, thanks for calling that out. It slipped right by me. All right. So, here's the deal. Unfractionated heparin gives you the idea that it's actually, let's start with this one. Okay, low molecular weight is kind of a range, and it's kind of a tighter range than this. This is why it's unfractionated. You got all sorts of lengths of heparin there. And the length actually has some role in how it works, okay? So the unfractionated, you got a whole mixture of them. The low molecular weight tends to be tighter with its mixture. Very variable half-life, very short time in the body. This one at least is more consistent with how fast it breaks down and lasts at least a little longer, 3 to 4 times longer. Okay, it's still 3 to 4 hours, but that's better than 1 hour. Let's see what else. This binds plasma proteins, so the problem is when you give heparin, a lot of it's going to grab onto the plasma proteins and you're going to have less available to do its effect. This not so much, so more of this when you give it actually gets in and does its effect. Excuse me. You got to give this more frequently. This is basically called generic heparin sodium or heparin calcium versus brand names for the low molecular weight or enoxaparin or deltaparin, okay? So those are the main differences I'd like you to keep in mind. Let's have a look at why they work differently. A little bit differently, the same too though. All right, you need at least 5 glycosaminoglycans for heparin to bind. So this is the heparin, this is the antithrombin 3. Heparin to bind and kind of get it to change its shape and do its job better. Unfractionated heparin, actually some of those longer chains, shorter chains only bind factor 10A basically, but that's okay because that's often all you need. All right. Longer chains can also bind. They can like wrap all the way around this whole thing. They'll wrap around thrombin that's bound to antithrombin. And so you also can inhibit factor 2. All right? So unfractionated heparin can inhibit both of these. So in essence, it's kind of a greater anticoagulant ability. It does a better job of stopping clotting. The problem is with pharmacology, you don't want to like blast every patient with a pharmacologic shotgun. You want to be a little more subtle, okay? So this one, it's easier actually to overdo it with the heparin. All right, this one only inhibits 10A, makes it better for long-term use. This tends to get used in like emergency rooms, short-term use. All right, but you can overdo it. So greater risk of hemorrhage, greater risk of low platelets. All right, so you got to watch your patients carefully. So that's why this one is preferred, especially for longer-term use. But again, in an emergency room, you might be reaching for this one, which is the unfractionated heparin, because you've got the ability to monitor your patient more closely there. And it would be temporary, and then maybe you can transition to the other one or to another anticoagulant. So that's the end of the drugs. I'm going to do a case Dr. Brainard shared with me just so you can have a feel for how these things play out in practice. Do you have drug questions? No? Okay, let's look at this case. So this is a 5-year-old male neutered Weimaraner going on a walk with him, and he suddenly starts having trouble supporting his rear limbs, and it's getting worse, while they're on the walk. So they bring them to your clinic. TPR is normal, capillary refill, mucous membrane's great, don't hear anything abnormal when you sculpt the chest. Abdomen seems good, but the rear limbs were cooler to the touch and couldn't really feel femoral pulses in this dog. You go down to the pedal pulses, you could feel a little bit on the left limb, not on the right limb. Also, neurologic exam, normal mental status. The gait, he was having trouble walking. His reflexes, his withdrawal reflexes were normal in the front, decreased in the rear. Proprioception, which is, the sense of place, that was okay. So what that's telling you is, the nerves are communicating with the brain and back, all right? So probably not a big spinal cord issue. You could have problems with withdrawal reflexes just if it's a neuromuscular problem, okay? So what do you think might be going on with this patient? What would you think if it were a cat, not a dog? Mm-hmm. Yeah, turns out he did have saddle thrombus, which is less common in dogs. So this is ultrasound, probably Doppler. This thing is the vena cava, and then this thing is the aorta, but this gray thing is the big blood clot sitting in it, okay? Right where it branches towards the limbs. They also did note he had very mild hypertension, but they couldn't find any other possible, at least evident cause of why this dog, his blood work and stuff was good. Other than, I suppose, his creatinine kinase would be elevated because when muscles don't get their blood supply, they like to break down. But, they couldn't find any evident reason. If you have hypertension, that does make you prone to blood clots. But this wasn't like severe hypertension, but, who knows? It might have contributed. So the cause was kind of unclear. So what did they do? Well, he's in the hospital. So they just started him on the regular generic heparin, the unfractionated heparin, okay? Given that IV, they started him on clopidogrel, which remember we talked about way in the beginning of the class is good for, in general, inhibiting coagulation. And they put him on amlodipine, which is a calcium channel blocker, which helps with hypertension. It's a very low conservative dose because he didn't have severe hypertension. They just wanted to take the edge off of it in case that was contributing. Okay, and start him on some physical therapy. In the hospital, dogs started walking better gradually, okay? They did this heat map thing, all right? Red is good blood supply, and if you remember, they could feel a dorsal pedal pulse here, but not so much here. Dog's able to move, still not getting a great amount of blood down here, and, you know, not perfect, but getting more blood down on the left side, all right? So blood flow was coming back. So ultimately, he got sent home. They did keep him on the unfractionated heparin, where the owner was given it sub-Q 3 times a day. Okay, they kept him on the clopidogrel, and they kept him on the amlodipine. And they checked him frequently. Okay, so this was the initial plan. You'll see the plan modified a little bit. Periodic rechecks, they wanted to make sure that clot wasn't building on the front end and was going to block off the renal arteries, which is like the next big, if I recall, the next big route off the aorta before you hit the hind limbs. All right. And they did some things that you may not have typically handy in a, well, some of them you would, in an average practice. Cornell University looks at anti-10A levels, and so they're able to kind of keep an eye on factor 10A. They did activated partial thromboplastin times, which is something that you can do in a regular veterinary clinic to assess the coagulation, the intrinsic and the common pathway. And their goal was to kind of keep them not just subtly anticoagulated. So clotting times elevate. Takes longer to clot when you're anticoagulated, so a bit longer than normal, but not greatly. This is a color flow Doppler, all right, and this shows the clot, the aorta. So here's blood coming in, and then here's blood kind of like squirting past it, okay? That's basically all that shows. Of course, when you have turbulent flow like that, that kind of likes to form clots too. So this dog kind of has a long-term problem now, where we got to keep them on the anticoagulated side. They also looked, remember the clopidogrel affects platelet aggregation, so they did a couple of tests to see how the platelets were functioning. Ultimately, the clot kind of remained static, maybe got a little bit smaller, not by great amounts though, and he walked better, which is important, all right? So they did decrease the heparin dose, but they checked an ultrasound and the clot seemed to be getting longer again. They're like, oh crap, we can't do that. So, but heparin, remember heparin can have some problems. They were using the unfractionated heparin. Also, even, you know, it's cheaper than the fractionated heparin, but it's not cheap, all right? So they wound up switching to rivaroxaban, okay? And they followed up with anti-10A factor measurements. Dog did well on this for 5 years. The clot kind of contracted down a little bit, matured some, but ultimately didn't get worse. And so that's 5 years out is the last word that he has on the dog. So you see some of the thoughts behind different choices of drugs there, but then also over time, the treatment plan modified a little bit to face some realities and decrease risks and things like that with the patient. So. I'm just going to mention a couple other drugs just so you've heard the names, not on the test. Okay, it might have occurred to you, remember that glycoprotein 2B3A receptor? Hey, what if we block that? And there are drugs that do that. They don't tend to be good as clopidogrel, and they haven't really found use in veterinary medicine, but you might have been thinking that. What if you overdo it with the heparin? There is something called protamine sulfate. And it's basically a protein chain, so heparin's got a bunch of negatives on it from the sulfates. This guy has just more like one sulfate on the end. The rest of it's positive, so it grabs onto the heparin and neutralizes it. Okay, it tends to have a lot of side effects. One of them, which I think is interesting, is that it's made from fish sperm. And so if for some reason, and apparently this is common, if you're allergic to fish sperm, you can have a reaction to it. So be careful. You've probably heard about tissue plasminogen activator, okay, which ultimately that starts breaking plasmin down, and then it frees plasmin. Okay, and plasmin then is that last phase where we start breaking the fibrin clot down. Okay, and so there are drugs, tissue plasminogen activator and also streptokinase, are two drugs. They haven't found much benefit in veterinary medicine for cardiovascular related clots. But if you, and I don't think you can see, there's a blood clot sitting in this horse's eye in front of the iris. It's used specifically in equine ophthalmology. If a horse is stupid and bangs its head and gets a blood clot in its eye, you inject that in there and it helps break up the blood clot. And then if you have hemorrhage, and so if you go into surgery, this might be good. Here's some splenic hemangiosarcoma and other reasons. You can have a belly full of blood, post-op bleeding, equine nasal surgery, aminocaproic acid and tranexamic acid. Basically what they do is they go in there and they block plasminogen, and so fibrin isn't blocked. So you'll get some clotting if you're hemorrhaging, assuming your clotting cascade and everything is normal. They'll block that, and then as clots form, they don't start getting lysed right away. So it gives you some benefit of basically augmenting coagulation if you have a hemorrhaging patient. The World Health Organization considers this an essential drug for postpartum hemorrhage in third world countries, and in the U.S. too, but we tend to have other things we can do. So that's the last one. Oh, exam hints, a couple of practice questions, and platelet party, because it's Friday. All right. Bad reaction to them hemorrhaging.
Yeah, but then if you want to reverse it, you give this fattening thing.
Yeah, good.
But will that warfarin, like currently in the system, still inhibit this? Or no? Is this like not going to be?
Yeah, you're kind of replenishing the ability there.
Okay, so you just like overcut however much warfarin is.
Yeah.
Okay.
So the problem is vitamin K doesn't get regenerated.
Okay,
You're
so
providing the regenerated form.
Okay.
But, yeah.
Okay, that makes sense. Thank you.